Cholangiocarcinoma is an oncological disease. Look at this picture, shows that liver and cancer cells in the bile ducts. Look at this. Then ultrasound findings, CT scan and MRI findings. Look at this. Then MRCP, magnetic resonance, cholangiopancreatography. Look at this picture. And findings. A detail going on. Introduction. Cholangiocarcinoma is a rare but aggressive form of cancer that originates in the bile ducts. The bile ducts are part of the biliary system. Which carries bile from the liver to the gallbladder and small intestine. Cholangiocarcinoma is often diagnosed at an advanced stage due to its subtle and non-specific symptoms, leading to poor prognosis and limited treatment options. Definition. Cholangiocarcinoma is a malignancy that arises from the epithelial cells lining the bile ducts. It is classified as an adenocarcinoma and is known for its rapid progression and high mortality rate. Etymology. The term cholangiocarcinoma is derived from Greek root chole, bile, angio, vessel or duct, and carcinoma, cancer, referring to a malignant tumor of the bile ducts. The name reflects the disease's origin in the bile duct epithelium, where abnormal cell growth leads to cancer formation. Types. 1. Intrahepatic cholangiocarcinoma (ICC) occurs in the bile ducts within the liver. 2. Peripheral cholangiocarcinoma arises at the junction of the left and right hepatic bile ducts. 3. Distal cholangiocarcinoma develops in the bile duct closer to the pancreas and small intestine. Causes. The exact cause of cholangiocarcinoma is not well understood, but genetic mutations and chronic inflammation of the bile ducts play a significant role in its development. Cholangiocarcinoma can have multiple causes, but five common risk factors include: 1. Primary sclerosis cholangitis, a chronic inflammatory condition that leads to bile duct scarring. 2. Liver fluke infections, parasitic infections, especially Opistho, Richus, Ivorini, and Colonorichus sinensis are linked to bile duct cancer. 3. Chronic biliary inflammation, conditions like recurrent bile duct stones or infections can increase cancer risk. 4. Hepatitis B and C infections, chronic viral infections contribute to liver damage and increase the risk of bile duct malignancies. 5. Toxic exposure, chemicals like thorotrust and other industrial toxins may contribute to cholangiocarcinoma development. Risk factors: 1. Chronic biliary inflammation. 2. Liver diseases. 3. Pancreatic infections. 4. Bile duct abnormalities. 5. Exposure to toxins. 6. Diabetes mellitus and obesity. 7. Smoking and excessive alcohol consumption. Complications: 1. Liver failure. 2. Biliary obstruction leading to jaundice. 3. Cholangitis, bacterial infection of the bile ducts. 4. Metatasis to distant organs. 5. Malnutrition and cachexia. Pathophysiology: cholangiocarcinoma originates from the biliary epithelium due to chronic inflammation, genetic mutations, and environmental insults. These factors leads to uncontrolled cellular proliferation, angiogenesis, and eventual tumor growth. The tumor infiltrates the surrounding tissues and spreads via the lymphatic and vascular systems. Cholangiocarcinoma is a malignancy of the bile duct epithelium that develops through a series of cellular and molecular changes in response to chronic inflammation, genetic mutations, and environmental factors. Below is a detailed step-by-step process explaining its pathophysiology. 1. Chronic biliary inflammation and injury. Trigger factors. Chronic inflammation due to conditions like primary sclerosing cholangitis, liver flux infection, viral hepatitis, HPV, HCV, bile duct stones, or toxic exposure. Then inflammatory response. Persistent bile duct irritation leads to the activation of immune cells, causing the release of pro-inflammatory cytokines. Then oxidative stress, reactive oxygen species and nitric oxide are generated, causing DNA damage and impairing normal cell repair mechanisms. 2. Genetic and epigenetic alterations. First, mutations in tumor suppressor genes, loss of function in genes like TP53, SMAD4, and CDKN2A disrupt cell cycle regulation and apoptosis. Next, oncogen activation. Overexposure of oncogens like KRAS, IDH1 bar 2 and FGFR2 leads to uncontrolled cell growth and proliferation. Then epigenetic modifications, abnormal DNA, methylation and histone modifications, Schillion's tumor suppressor genes, further promoting malignant transformation. 3. Aberrant cell proliferation and dysplasia. First, uncontrolled cell growth. Mutations in growth factor pathways promote unregulated cholangiocyte proliferation. Next, biliary epithelial dysplasia. Normal bile duct cells undergo metaplasia and dysplasia, characterized by cellular atypia, loss of polarity, and increase mitotic activity. 4. Neoplastic transformation and tumor formation. Escape from apoptosis, tumor cells develop the resistance to programmed cell death via anti-apoptotic proteins like BCL2 and MCL1. Then angiogenesis induction. Cancer cells secrete VEGF, vascular endothelial growth, factor, stimulating new blood vessels, formation to supply nutrients and oxygen. Then immune evasion. Tumor cells inhibit immune surveillance by upregulating PDL1, which suppresses T cell activity. 5. Inversion and metastasis. Local inversion tumor cells breach the basement membrane and invade surrounding liver tissue and bile ducts. Then lymphatic and hematogenous spread. CCA metastasize to regional lymph nodes, peritoneum and distant organs like the lungs and the bones, epithelial mesenchymal transition EMT, tumor cells loss epithelial markers and gain mesenchymal properties, enhancing their motility and invasiveness. Cholangiocarcinoma develops through chronic inflammation, genetic mutations, and dysregulated signaling pathways leading to uncontrolled cell growth, inversion, and metastasis. Its aggressive nature and late stage diagnosis contribute to poor prognosis, highlighting the need for early detection and targeted therapies. Signs and symptoms. 1. Jaundice. 2. Abdominal pain. 3. Unintended weight loss. 4. Itching. 5. Dark urine and pale stools. 6. Fatigue and malaise. 7. Fever if infection is present. Diagnosis. 1. Blood test, liver function test, tumor markers. 2. Imaging studies, ultrasound, CT scan, MRI, MRCP. Magnetic resonance, cholangiopancreatography. 3. Biopsy, percutaneous, endoscopic or surgical biopsy for histopathological examination. 4. Endoscopic retrograde cholangiopancreatography used for visualization and possible stenting. 5. Positron emission tomography PET scan to evaluate metatasis, nursing diagnosis. 1. Impaired liver function related to biliary obstruction. 2. Acute or chronic pain related to tumor growth. 3. Imbalanced nutrition less than body requirements related to anorexia and weight loss. 4. Anxiety related to disease prognosis and treatment. 5. Risk for infection related to biliary obstruction and cholangitis. Management. 1. Surgical resection, the only curative treatment for localized tumors. 2. Liver transplantation for selected patients with peripheral cholangiocarcinoma. 3. Chemotherapy. Gemcitabine and cisplatin are first line agents. 4. Radiotherapy used for palliation or post surgical treatment. 5. Targeted therapy FGFR and IDHI inhibitors for genetic mutations. 6. Palliative care, biliary stenting, pain management, and nutritional support. Nursing management. 1. Monitor liver function and signs of jaundice. 2. Manage pain with prescribed analgesics. 3. Provide nutritional support, high protein, low fat diet. 4. Education patients on symptom management and treatment options. 5. Provide emotional support and facilitate palliative care if needed. Treatment options. 1. Surgical resection, partial hepatectomy or bile duct resection. 2. Liver transplantation for patients with early stage peripheral cholangiocarcinoma. 3. Systemic chemotherapy, gemcitabine based regimens. 3. Radiotherapy, external beam or brachytherapy for symptom control. 4. Palliative interventions, stent replacement, pain management, and nutritional therapy. Psychosocial medicine. 1. Counseling and psychological support, helping patients and families cope with diagnosis. 2. Support groups, encouraging participation in cancer support groups. 3. Spiritual care, providing religious or spiritual support as per patients' beliefs. 4. Family involvement, educating and involving family members in care. 5. Stress management techniques, meditation, relaxation, and guided imagery. Prevention: 1. Avoidance of liver flaky infections by proper food hygiene. 2. Vaccination for hepatitis B and proper management of hepatitis C. 3. Reducing alcohol and tobacco use. 4. Regular monitoring for individuals with risk factors. 5. Early treatment of biliary tract diseases. In conclusion, cholangiocarcinoma is a challenging and often fatal malignancy due to late diagnosis and limited treatment options. Early detection and multidisciplinary management can improve survival rates. Preventive measures such as avoiding liver flaky infections and managing chronic liver diseases play a crucial role in reducing the incidence of this cancer. Continuous advancements in medical research are providing new hope for targeted therapies and better treatment outcomes. Thank you. Have a nice day.